what they did is they took those and turned it into this. So this is actually part of the report. Okay. So here's your 2C9, 2C19, 2D6, 3A4, and so 2C9 they broke it down into beta blockers, etc. And 2C19, and antidepressants, antiplatelets. Yeah. So. Murmur. Okay, so when you're talking to your pain doctors, here's your commonly prescribed pain medications and the pathways. So once again, if you're not metabolizing hydrocodone, which primarily goes through 2D6, might want to switch to fentanyl or something like that, which goes through a different pathway. The pain report has green, yellow, red with some drugs, but like I said, gives you your implications and therapeutic recommendations again. And the urology and psych all you look at those same pathways, but it's not a big revenue producer for the physician. There's a G code that came out last year. It's a temporary code that it was an original pathology code that says that in certain situations practicing physicians can use it when deemed necessary. So there's a G code that they can bill to get roughly $18 for looking at the data, interpreting it, and then like what we said, it's totally within the realm to bring that patient in, go over the metabolizer status, like Dr. Topol says, and go over the pathways so they can understand it. And we actually developed some posters that are on the wall back there so that you can see their metabolizer status, and you can put those in the doctor's office so you can explain the results that, hey, if you're a poor metabolizer, it just sits in your system, doesn't move that quick, and so you don't need as much. And then the people that are ultra rapid, you need more than the average dose just because you burn through it very quickly. So I put this in here so from a sales standpoint, you get more reimbursement for the personal medicine panel because there's more genes that are looked at and more risk factors, so there's a higher reimbursement to the lab, thus to you. So if you're selling it to a pain physician, why should they do a personalized medicine panel that brings everything into play as opposed to just pain? Well, is it important to know factor 2 or factor 5 for your spinal cases, or a knee or a hip, when you're going to have a sedentary patient and they're at extremely high risk? What happens is if you have one of these factor 2, if you just have one of these that comes up red for factor 2 or factor 5, you're at a very increased risk of, it's down to like 1 in 125 have a risk of developing a DVT or pulmonary embolism. But if you actually have both present, it's about 1 in 12. So it's like what do you want to know that one patient per year that you're going to have, and just eliminate that completely from being catastrophic.
Right. If your patient actually has either one of those, then they have to be on Coumadin for life.
Right.
That's what.
Do they?
Yep. Coumadin for life. If they develop, I actually had 3 patients one night in the emergency department that came in with factor V line deficiency. 3 in one 12-hour shift. 2 of them actually came in.
Is it Coumadin, or does it have to be Coumadin, or could it be like Xarelto or Pradaxa?
Well, right now it's Coumadin. Xarelto and Pradaxa, they're actually studying it, but right now it's Coumadin. One of the patients actually, she was known to be factor V Leiden deficient. She had developed a PE already in the past, and she was on the Coumadin for a year, and then her doctor took it off of it. And even though she knew she was factor V Leiden deficient. So what did she come in with? She had pulmonary embolism.
Oh, wow.
She came in with shortness of breath, she couldn't walk or nothing like that. She had a PE. Started on heparin as soon as I saw her, and I found out she was factor V Leiden deficient. The second patient, and then her son, who also was factor V Leiden deficient, has been on Coumadin ever since they found out, and although he never developed DVT or PE. The second patient that I saw that night ended up having a PE, but on the inpatient side of it was found to have factor II deficiency. Okay, and then again, Coumadin for life as well.
Goes back to this,
yeah,
right?
exactly, right there. And then I had a third patient as well who came in with factor V Leiden deficiency, who told me was taking their Coumadin, ended up having a DVT, but then confessed to saying, yeah, I stopped taking my Coumadin about 3 months ago. All in one 12-hour shift. Now, what are the chances? But still, nonetheless, what Ed was talking What Ed was talking about here is that if that pain doctor doesn't want to care about the factor II and factor V, well, you know what? They're not doing their patients any favors then.
Well, how many people that have a PE die?
I think the number initially were talking about like 100,000 patients a year die from PEs annually. But a lot of them also are usually associated with postoperative patients. Yeah. But a lot of these postoperative patients end up actually having factor II or factor V Leiden deficiency, but nobody ever knew that.
They don't know. Right. Well, we had one the other day.
You did?
Well, I didn't, but yeah.
Yeah.
The doctor I work with.
But see, that's the whole point. So make this standard pre-op clearance mandatory on all your patients going for hip, spine, because like, okay, so what happens here, there's a physician, I hate to say really like that, because like, I'm still learning too, because this physician that I work with in Atlanta, he actually wrote a paper in 2009 about using genetic testing for total knee and hip patients, because I didn't realize that 60% of patients, when they go for a total knee or total hip, get put on Coumadin. Okay, so
After.
yes. Yeah. Okay, so the results that we provide from the Mayo Clinic here, I'll show you the results right here. The results published by Mayo show that there's a 31% reduction in hospitalization within a 6-month period using genetic guided therapy. So 25% of the patients are, this is a 3,500 patient Mayo study. 25% of the patients are going to end up hospitalized within 180 days of initiation of Coumadin. Using genetically guided therapy is down to about 17 or 18%, which is a 31% reduction. But also, there's the patients that use it, the genetic guided therapy got to stable INR 2.7 days earlier, and they stayed in range longer. So there's significant evidence to use this, and so once again, it goes hand in hand. That's why I got so excited, because why do you want to use this test? Well, I didn't realize that until you just said that if you show up positive for factor II or factor V,
Coumadin for life.
Coumadin for life.
Right. The other thing, the reason why these patients are going on Coumadin postoperatively is because they're basically being shotgunned by the orthopedic, saying that you're at risk for developing a DVT because of the orthopedic procedure. Now, they're not going to necessarily test them for a factor II or factor V, and if they are smart, they would, and they would know beforehand that they are factor II or factor V deficient, so of course they're going to go on Coumadin on top of that. But the flip side of that is also, with the Coumadin therapy, again, you take a patient, and the generic thing is, we're going to start you on 10 milligrams of Coumadin for 3 days, and then taper it down afterwards based on what your numbers show. Right. But with this genetic test we do, if you do it up front, then you already know that one size doesn't fit all kind of model, and we'll know exactly where to put you, what dosage to put you on 3, 5, 6 days hence from now, and then decrease what Ed was talking about, your complication rates, either from because they developed a DVT because their INR wasn't high enough because their dose was too low, right, or they developed a bleed because their dose, although it was a normal dose, ended up being too high for that patient because their pathways, they just metabolize too quickly.
Is there a difference between the knee and the hip?
No.
No.
It's on the package. This is the package insert of Coumadin.
Just
right?
thinking because they go down the canal more on the hip, so I was thinking it'd be more. Who did that study in Atlanta?
Dr. Kakaria.
So it's
Do
kind
you
of
have that? because we would like to, that's
Yeah.
something we need.
That'd be helpful. So it's just like a blanket thing that they're doing. They're putting
Yeah, it
everybody
should
on
be,
Coumadin just to basically cover their ass, excuse my French. But
No, it's
if
because
we-
it's a recommendation based on
Right.
the fact that they're at risk for a post-op.
Well, they all put them on Coumadin. I mean,
Right.
that's what we see it every day.
yeah, every day, and then whether they need to be on it or not.
Right.
Right.
Well, no, they
Well,
need to
they
be on
have
it because they're
factor
gonna,
five.
because they're post-op surgery, orthopedic post-op surgery, and they're gonna be at risk for a DVT then, so
Right.
they do that, blanket. And that's a standard of care for the
Sure.
country.
Clinical outcomes on the study for warfarin initiated in orthopedic patients. It's right here on the website.
On the website. But this is a way to introduce it to the, when you're
Right.
talking to the doctors in the doctor's offices, it's sort of introduce that, the different aspects of the test and why they should be doing it then.
Right.
So, like I said, there's stuff in here, you know, so go through it so you're armed, you know, so
Right.
that,
That's big.
you know, what I want to do is like, you know, that I want to take something that's as complex as sequencing your genetics and dumb it down to where you kind of have that aha moment and makes sense to do it as opposed to not do it. You know, Dr. Tu was saying that he had he was talking to some cardiologists and they just wouldn't buy into the fact that you need to do this because the AHA hasn't had a consensus statement. Okay, so what's happening now in cardiology, if I start having a STEMI, heart attack, whatever, need a cath, get a stent, they're going to